Imagine going to a clinic, right, with just debilitating, life-altering chronic pain. And the absolute most effective treatment the doctor can offer you is, well, a literal injection of salt water.
Yeah, which sounds completely absurd on the surface. But we are diving into a diagnostic landscape today that really challenges everything we think we know about how to treat physical pain.
Right. Welcome to today's deep dive. We have a highly specific, frankly, intensely curious mission for you today. We're exploring a question that lives right at the intersection of anatomy, neurology, and pain management.
And it is a fascinating intersection to explore.
It really is. So we want to know, can a targeted trigger point injection, specifically using lidocaine into the bulbocavernosus muscle, provide short-term diagnostic relief or longer-term benefit in selected cases for entryway penetration pain?
I mean, it's a laser-focused medical question, obviously,
Right.
but the implications here for anyone suffering from, any kind of chronic pain are just massive.
Absolutely. And to get to the bottom of this, we've got this towering stack of clinical sources to sift through for you. We're looking at medical policies from Blue Cross Blue Shield, anatomical guides from the National Vulvodynia Association, and various clinical trial reviews on pelvic floor disorders.
Which is a lot of dense material. There are a lot of
Yeah.
competing theories and data in these documents, to put it mildly.
Yeah, so, okay, let's unpack this. What is our baseline strategy for making sense of it all today?
Well, our mission today is basically twofold. First, we need to separate the mechanical action of this treatment from its neurological effects.
Right, like what the needle is doing versus the drug itself.
Exactly. We have to figure out what the physical needle is doing versus what the chemical drug is doing. And second, we have to look at what the clinical data actually proves regarding short-term diagnosis versus long-term healing.
Because, as we dive into these trials, the theoretical science and the real-world data do not always perfectly align, do they?
Not at all. Sometimes they violently contradict each other, which means before we can even begin to understand the cure, we absolutely have to understand the location.
Yeah, that makes sense. So to grasp why this specific injection is used, we have to map out the anatomy of the pelvic floor, which our sources note is incredibly misunderstood by the general public.
It really is. I mean, a lot of women spend years wandering from specialist to specialist, just wondering what is fundamentally wrong with their bodies. And it's largely because the basic vocabulary we use for female anatomy is often generalized or just flat out incorrect.
Right, just totally inadequate.
Yeah.
So just to make sure I'm picturing the anatomy accurately here, based on the National Vulvodynia Association guides, distinguishing the vulva from the vagina is basically like distinguishing the lips on your face from the inside of your mouth, right?
That is a perfect analogy, actually. Yes.
So the vulva is the external architecture, like the lips, and the vagina is the internal passageway, like the inside of the cheek. You wouldn't put lip balm on the inside of your cheek.
No, you definitely wouldn't. And that distinction changes everything about how a physician approaches treatment. If a patient has a condition originating in the external tissue, attempting to treat it by inserting medication or therapies internally is, well, it's going to be completely ineffective.
Right. So keeping that lips versus mouth analogy in mind, the sources zoom us in on a very specific, narrow piece of real estate today called the vestibule,
Yes, the vestibule.
which is the tissue directly surrounding the vaginal opening. And the pain condition we are focusing on is known as provoked vestibulodynia, or PVD.
And what's really fascinating here is the word provoked.
How so?
Well, this isn't a constant, spontaneous, radiating ache that happens when a person is just lying still.
Yeah.
Provoked vestibulodynia means the pain occurs specifically and exclusively with touch or pressure.
Oh, I see.
Yeah, so that could be during sexual intercourse, during a standard gynecological exam, or, even just the friction from wearing tight pants or sitting down on a hard chair for too long.
Wow. Okay, so if the pain is happening right at the entrance like that, I'd imagine there's a specific structure there taking the brunt of that pressure. Like, is there a muscle right beneath that sensitive tissue?
There is, and it's a major focal point of our clinical sources today. The pelvic floor is this really complex, interwoven hammock of muscles, ligaments, and nerves.
Right, it holds everything up.
Exactly. It supports the reproductive organs, aids in bladder and bowel control, and is deeply central to sexual function. And the specific muscle taking the brunt of the pressure here is the bulbocavernosus muscle.
The bulbocavernosus muscle. Okay, the documents describe it as part of the urogenital triangle. What does it actually mean in plain English?
It just means it's one of the superficial muscles of the pelvic floor. It wraps right around the vaginal opening.
Superficial meaning it's close to the surface.
Right. Because it is superficial, it's accessible externally. A physician doesn't have to go deep into the pelvic cavity to reach it or treat it.
But why does this specific muscle, doing its normal supportive job, suddenly become the source of so much localized agony?
Well, the culprit in these cases is often something called a myofascial trigger point.
Okay, trigger points. I hear that term a lot from massage therapists, usually when they're working out like a stiff neck or a bad back. But in a clinical sense, what actually is it?
So a trigger point is a discrete, focal, hyper-irritable spot located within a taut band of skeletal muscle fibers.
So a tiny piece of the muscle just freezes up.
Essentially, yes. A tiny segment of the muscle fiber has contracted and locked into a shortened position, and it just refuses to release.
Sounds painful.
It is. When that specific spot is stimulated or pressed, it produces intense local pain and sometimes even referred pain.
Referred pain meaning you feel it somewhere else.
Right. The nervous system gets confused, basically, and you feel the pain in a completely different nearby area.
Okay, so it's essentially like getting a severe cramped knot in your shoulder, but located in an incredibly sensitive, nerve-dense area responsible for structural support and sexual function.
A localized, rigid nodule, yeah. And because of the sheer density of nerve endings in the pelvic floor, a knot down there doesn't just cause a dull ache. I mean, it can completely disrupt a person's quality of life.
Okay, I get the mechanics of the knot. That makes total sense. But I'm struggling with the treatment protocols in these sources.
Which part?
Well, if the problem is just a tight band of muscle, why are doctors taking a syringe and injecting a numbing agent, like lidocaine, directly into it? Why not just do targeted physical therapy and massage it out like a normal knot?
That's a great question. The clinical strategy behind the lidocaine injection actually has two distinct phases. And the first phase is purely diagnostic.
Okay.
This answers the first part of our mission today, the short-term diagnostic relief.
Right. But how does a painkiller function as a diagnostic tool? Are we just numbing the area to see if the patient stops complaining, or is there like a specific mechanical test happening here?
Think of it like dealing with a complex wiring issue in your house where a light keeps flickering.
Okay, I'm with you.
You aren't entirely sure which specific wire behind the drywall is causing the short circuit. If you cut the power to one specific wire and the flickering immediately stops, well, you've definitively found your culprit.
Ah, I see.
That is exactly what a targeted injection of 1 cc of 1% lidocaine does.
Because lidocaine is a local anesthetic, it shucks the power off.
Exactly. By using a needle to inject that anesthetic directly into the hyperirritable trigger point in the bulbocavernosus muscle, the physician immediately blocks the central pain response originating from that specific anatomical spot.
Oh, wow, I see the logic now. So the doctor administers the injection and then immediately tries massaging the area or applying the pressure that would normally provoke the severe pain.
Right. And if the patient feels absolutely nothing,
The diagnosis is locked in.
completely, the physician knows definitively that this specific muscle and this specific nerve pathway is the root source of the pain.
So they can cross a bunch of other scary stuff off the list.
Yeah, they can confidently rule out a systemic infection, a dermatological condition, or a broader neurological disease. They found the bad wire. It is that myofascial trigger point.
As a diagnostic tool, that is incredibly elegant. I love that. It's a temporary power shutoff to test the circuit. But here is where I get really hung up on the second part of our mission.
The longer-term benefit.
Yeah, the therapeutic side of it. Lidocaine is a short-acting drug. It has a half-life of, maybe an hour and a half?
Somewhere around there, yeah.
It wears off very quickly. So how can a temporary numbing agent possibly provide longer-term healing? Once the drug is flushed out of the tissue, shouldn't that not just start screaming again?
If we connect this to the bigger picture, we really have to rethink our entire concept of pain. Chronic pain doesn't just live in the muscle itself.
Well, wait, it doesn't. Where does it live?
It fundamentally alters the nervous system.
Oh, okay. So we're moving past just a cramped muscle and getting into the actual neurobiology of chronic pain.
We have to. When pain becomes chronic, the body enters a permanent state of high alert. And this involves two distinct processes: peripheral sensitization and central sensitization.
Okay, let's break those down. Peripheral meaning local.
Right. Peripherally, meaning right there at the local tissue level, the bulbocavernosus muscle, there is neurogenic inflammation.
Because of the knot.
Yes. The constant muscle tension restricts blood flow, which creates this acidic, oxygen-starved environment.
And the nerves trapped in that tight, acidic environment react to that stress.
Violently. We really have to look at the nociceptors here.
Nociceptors, those are the pain receptors, right?
Think of nociceptors as your body's dedicated threat detectors. They're specialized nerve endings. And in this hostile, clamped-down muscle environment, these nociceptors become totally hyperactive.
It's like a car alarm going off constantly.
Exactly. And they start releasing pro-inflammatory cytokines, specifically a neuropeptide called substance P.
Substance P, like a chemical flare gun signaling that the tissue is under attack.
A flare gun that triggers a whole cascade of awful things. Substance P causes local mast cells to degranulate and just dump histamine into the surrounding tissue.
Wait, histamine, like the same chemical that causes my nose to swell up and run during allergy season?
The very same.
Mm-hmm.
Histamine promotes vascular permeability and severe inflammation.
Oh, man.
So now you have these hyperactive peripheral nociceptors sitting in a pool of inflammatory chemicals just screaming at the brain constantly.
And that's where the central sensitization comes in.
You got it. This constant screaming creates a vicious negative feedback loop to the central nervous system. Over time, the brain physically rewires itself to become more sensitive to pain signals from that region.
I mean, if you've ever had a chronic injury, like a bad back or a lingering shoulder issue, this is exactly what your brain is doing. It's like the volume dial on the pain receiver gets stuck at a 10, and the brain literally forgets how to turn it back down even when the original injury starts to heal.
It's a perfect analogy. So returning to your question about how a short-acting drug like lidocaine provides long-term relief, it breaks the loop.
By turning off the alarm.
Exactly. Repeated exposure to lidocaine doesn't just numb the area. It actively diminishes the release of histamine from those mast cells.
Oh, so it stops the chemical cascade itself?
Yes, it reduces that localized neurogenic inflammation right at the cellular level. Furthermore, it desensitizes those hyperactive nociceptors.
It forces those threat detectors to just chill out and stop dumping substance P into the tissue.
By repeatedly breaking that peripheral pain cycle with the lidocaine injections, you stop the flare gun from firing. You inhibit that constant negative feedback loop to the central nervous system.
You give the brain a much-needed timeout.
A window of absolute silence, allowing it to reset that volume dial you mentioned earlier. Thermodynamically and chemically, it halts the runaway train of chronic pain.
Okay, I get it now. We know how it works in theory, down to the cellular receptors and the substance P release. And this is but what happens when you actually test this on humans in clinical trials?
Ah, the real world.
Because a theory that clean rarely survives contact with the real world, right? You find the knot, you inject the lidocaine, you stop the histamine, you reset the brain. It just sounds a little too perfect.
Well, this raises arguably the most difficult question in pain management because, as you suspect, the clinical data is rarely that clean.
Let's get into the messy data then.
When you look at the studies in our stack, particularly those utilizing ultrasound-guided injections to accurately hit the muscles of the levator anti-sling.
Which is the broad sheet of muscle holding up the pelvic organs, right?
Yes, and the bulbocavernosus, there are indeed statistically significant improvements.
Yeah, I saw that data. Patients were showing real measurable improvement on the visual analog scale for pain, the VAS. Like, they were getting quantifiable relief from the injection.
They definitely were. But then we have to examine the comprehensive medical policy reviews. Specifically, the massive summaries provided by organizations like Blue Cross Blue Shield.
Right. And this is where the diagnostic waters get incredibly muddy.
Very muddy.
Because the Blue Cross Blue Shield review kind of throws a massive wet blanket over the entire thermodynamic theory we just discussed.
It injects some intense data-driven skepticism for sure. According to their review of multiple randomized controlled trials, injecting lidocaine into trigger points does improve subjective pain ratings.
Okay.
But they found that it sometimes only improves those ratings to the exact same degree as conservative physical therapy, or, and this is the kicker, even just wearing a topical lidocaine patch on the surface of the skin.
Wait, sticking a patch on the outside of the skin works just as well as driving a needle deep into the muscle fiber to reset the nervous system.
In several trials, the outcomes were statistically indistinguishable.
That is wild.
And even more surprisingly, the review states that the deep lidocaine injections performed only slightly better than a sham stimulation.
A sham stimulation, meaning a placebo.
Exactly. They also analyzed randomized studies comparing trigger point injections using bulbocaine, which is another powerful, long-acting anesthetic, against injections of plain saline.
And saline is just sterile salt water. It has absolutely zero anesthetic or chemical properties.
Right. And those double-blind studies found absolutely no differences between the groups in pain reduction or restored function.
let me make sure I am grasping the magnitude of this. You're saying that injecting a powerful numbing agent into a localized muscle knot resulted in the exact same pain relief as injecting plain salt water.
The primary outcome in those specific trials showed almost identical drops in pain scores at 30 to 60 minutes for both the bulbocaine group and the saline group.
So is the lidocaine doing anything chemically at all, or are we just looking at the mother of all placebo effects here?
We are definitely looking at a placebo effect, but we need to, I think, redefine what placebo means in the context of chronic pain.
Okay, how so?
It doesn't mean the pain is fake or all in the patient's head. The pain is agonizingly real. What this suggests is that the ritual of the treatment, the authoritative doctor, the cold ultrasound gel, the physical prick of the needle, the clinical setting.
All the medical theater.
Exactly. It creates such a profound expectation of relief that it triggers the brain's descending pain modulation system.
The descending pain modulation system, meaning the brain actively sends a signal down the spinal cord to intercept and block the pain.
The brain literally floods the central nervous system with endogenous opioids and neurotransmitters like serotonin and noradrenaline. It's physically closing the gate on those pain signals at the spinal level.
Wow.
The powerful belief in the cure chemically manifests the cure.
That is incredible. But wait, we can't ignore the physical reality of the needle itself either, right? Because one of the sources talked about the mechanics of dry needling.
Yes, dry needling is another huge piece of this puzzle.
Yeah.
That's inserting a thin needle into a trigger point without delivering any medication whatsoever, not even saline.
Just the metal needle.
Just the needle. The very mechanical act of a needle piercing, that taut, locked band of muscle fiber, can cause what is known as a local twist response.
Oh, like the muscle jumps.
Yeah, it mechanically disrupts the contracted sarcomeres, which are the microscopic units of the muscle, forcing them to abruptly release and relax.
So wait, when a patient gets a lidocaine injection and feels better long term, it could be the lidocaine halting the histamine release and resetting the nociceptors?
Yes.
Or it could be the physical needle mechanically breaking up the muscle fibers, like dry needling.
Yes, it could be.
Or it could be the brain's descending pain modulation system shutting down the spinal gate because the ritual of the clinic triggered a massive placebo response.
Or, most likely, a messy, overlapping combination of all three.
I mean, no wonder it's so hard to study.
And to add another layer of absolute complexity to this deep dive, this conundrum isn't isolated to just lidocaine. Let's look at another popular injectable mentioned in our clinical sources, botulinum toxin A, commonly known as Botox.
Botox. Now, Botox makes intuitive sense for this. It's a paralytic. It stops muscle spasms.
Oh.
If the whole problem is a locked muscle knot, paralyzing the muscle should solve the issue instantly, shouldn't it?
Physiologically, it is a brilliant strategy. Botox inhibits the release of acetylcholine from the nerve fibers, which stops the muscle from contracting entirely.
Right.
It also inhibits the release of glutamate and substance P, which, as we discussed earlier, directly decreases that peripheral and central sensitization.
It sounds like the ultimate magic bullet for provoked vestibulodynia.
You'd think so.
Yeah.
But the clinical data is, once again, totally contradictory.
Of course it is.
We have a major study in our stack by Peterson, a rigorous double-blind randomized placebo-controlled trial. They injected Botox into the bulbocavernosus muscle of women suffering from provoked vestibulodynia.
And the result?
They found zero significant difference in pain reduction between the Botox group and the saline placebo group.
Wait, no difference at all.
None. Both groups improved significantly, which again points back to that massive placebo effect of the clinical ritual.
Wow.
The researchers theorized that just the act of participating in a clinical trial, receiving focused medical attention and validation for their pain, provided the therapeutic benefit.
Just being heard and treated made the difference. That's crazy. But the stack of sources also includes a study that had wildly different results with Botox, right?
It does. The Fondazione Alessandra Graziatin review details open-label studies and case series where Botox injections were profoundly successful.
Okay, so what did they do differently?
In their own data of 37 patients, they were treating women with primary idiopathic vaginismus.
Okay, let's define that really quick. Idiopathic meaning they don't know the underlying structural cause, and vaginismus meaning
the involuntary reflexive spasm of the pelvic floor muscles. These patients had severely hyperactive pelvic floors. To treat them, the doctors used electromyographic guidance, EMG.
EMG, how does that work?
They essentially listened to the electrical noise of the muscle to find the loudest, most hypertonic, spasming fiber in the levator antemuscle.
So they weren't just guessing, they found the exact angry fiber.
Precisely. After injecting the Botox precisely into those hyperactive fibers, about 65% of the affected women achieved a permanent benefit.
Permanent.
Yes, they fully recovered and resumed normal sexual function.
Man, 65% achieving permanent benefit is a staggering contrast to the placebo-controlled trial that showed zero difference.
So what does this all mean?
Well, the successful cases utilized EMG guidance to ensure exact microscopic placement, and they were treating patients whose pain was heavily driven by active, involuntary muscular spasm vaginismus rather than purely nerve-driven pain like vestibulodynia.
I see. Different mechanism of pain. Exactly. It perfectly illustrates how incredibly difficult it is to standardize treatment for pelvic pain. The sources state plainly that because these disorders raise so many diagnostic controversies, no general therapeutic guidelines have yet acquired universal consensus.
It's just wild how we can understand the exact thermodynamic chemical mechanism of how a drug should work, down to the histamine receptors and the substance P release, but the moment you put it into a living human body, the results scatter in a dozen different directions.
It all depends on needle placement, muscle type, and the patient's own psychology.
It really is a puzzle.
That is the beauty and, frankly, the intense frustration of the human nervous system.
Yeah.
It's not a machine made of static wires and switches. It is a highly adaptive, predictive organ that is constantly being influenced by psychology, environment, and physical stimuli, all at exactly the same time.
Well, we have covered some serious ground here. Let's recap. We started with a very specific mission. Can a targeted trigger point injection using lidocaine into the bulbocavernosus muscle provide short-term diagnostic relief or longer-term benefit for entryway penetration pain?
And I think we can say the answer is a heavily qualified yes.
Definitely. The sources confirm it is incredibly useful as a short-term diagnostic tool. Like you said, if the doctor numbs that specific superficial muscle and the provoked pain disappears, they have successfully isolated the geographic location of the short circuit.
Exactly. And therapeutically, the cellular science strongly supports the potential for long-term relief. Repeated lidocaine exposure can halt that histamine release, calm the nociceptors, reduce neurogenic inflammation, and help reset the central nervous system's heightened pain loops.
Even if the clinical trials prove that it is notoriously difficult to separate that chemical relief from the mechanical dry needling effect, or the brain's own incredibly powerful descending pain modulation system.
Right. But honestly, whatever is doing the heavy lifting, the drug, the needle, or the brain, the patient can experience real, life-changing relief.
And achieving that relief quickly is paramount, not just for the patient's immediate quality of life, but for the long-term health of their entire pelvic region.
Which brings us to one final, deeply concerning concept buried in the neurology literature regarding why we absolutely must treat these localized pain points before they escalate.
Yeah, I wanted to bring this up. What happens if the trigger point is just left alone? Like if you just try to ignore the pain?
You trigger a phenomenon called cross-sensitization.
Cross-sensitization.
The pelvic floor is a tight, incredibly crowded neighborhood of nerves. You have the pudendal nerve, the posterior femoral cutaneous nerve, the ilioinguinal nerve, and their territorial maps heavily overlap.
So the wiring basically crosses over itself within the tissue.
Because of this heavy overlap and innervation, a localized, untreated, highly sensitized structure of like just a single ignored trigger point in the bulbocavernosus can actually upregulate an adjacent, perfectly normal structure.
Upregulate, meaning the surrounding healthy tissue becomes hypersensitive and painful too, even though there is no physical knot there.
Yes, the pain literally spreads.
Oh, wow.
The constant, unchecked firing of the inflamed nerve pathways spills over into the overlapping nerve pathways of the healthy tissue. If you leave that one small trigger point untreated, the brain's central sensitization doesn't just intensify the local pain, it expands its geographic map.
That is terrifying.
It is. What starts as provoked pain in one tiny spot of the vestibule can spread into generalized unprovoked chronic pelvic pain, affecting the bowel, the bladder, and adjacent muscles that were previously completely healthy. It's basically a race to stop the nervous system from rewriting its own pain map.
So treating localized pain isn't just about making the patient comfortable in the moment. You have to put out the fire before the nervous system permanently burns down the healthy tissue next door.
Exactly.
That is a terrifying but really fascinating reality to leave on. Keep that in mind next time you think about how your own body processes a lingering ache. Don't just ignore it.
Yeah.
Absolutely.
Until next time.